Our first session is going to be very inspiring. It's entitled Selecting a Target in Cancer Therapeutics, Personalized Cancer Therapy. And our lead-off speaker is Bill Sellers from the Novartis Institutes of Biomedical Research. Bill is going to speak about targeting critical oncogenic pathways in cancer, emerging molecules, and translational strategies.
I'd like to thank Dan and Bruce for inviting me. It's a real pleasure to be here. Next slide. Next slide. Okay, so I want to begin by framing the conversation around the paradigm that's been established by the treatment of chronic myelogenous leukemia with imatinib. And I think it's fair to say that the diagnosis of CML previously was generally attributed to a progression to accelerated blast crisis and eventually to death prior to the advent of Gleevec. And we know that the paradigm that's been established here was to understand CML not as a cancer of the bloodstream, but really as a genetic disease driven by the fusion of the BCR-ABL oncogene created by the translocation of chromosomes 9 and 22. And based on the understanding of activation of the Abelson kinase, imatinib was elaborated as an Abel kinase inhibitor. And if one looks at the incidence and then mortality rate since 1997, one can see that in 1997, 4,300 or 4,500 patients or so were diagnosed every year, and that remained unchanged over the last 13 years. And in 1997, about 2,500 patients a year died of the disease. Imatinib was introduced in 2001. One can see, not in a clinical trial, but instead just by looking at the statistics that are published by the Cancer Journal of Statistics every year, that the mortality rate of the disease fell from 2,500 a year to 450 a year. And you can see it appears that the mortality rate has stabilized at around 450 patients per year. But that's actually somewhat misleading because of the increased number of patients that are surviving, the prevalence of the disease has actually gone up quite dramatically. So the number of patients that are at risk to die every year is substantially higher now than it was in 1997, which means the mortality rate per patient prevalence is actually falling quite dramatically and continues to fall. So one of the questions, next slide please, that one can have is this paradigm generalizable, or is somehow this just an abnormality of CML, a idiosyncrasy of a simple genetic disease that happens to be in the bloodstream? And I like to show this particular slide because it's the first patient that was treated who had a KIT mutant melanoma. So this is a rare form of melanoma, first described by Boris Bastian, that harbors activating mutations in the KIT oncogene. And the first patient that was treated with Gleevec on this on a phase 2 trial showed this response, in which you can see the pre-treatment PET CT scan followed by the post-treatment PET CT scan. And I like this example because I think many people would have described melanoma as intrinsically refractory to therapy. In fact, you can probably go back in the literature and find all sorts of papers on why melanoma was intrinsically resistant to chemotherapy, instead of why don't we understand the pathogenesis of melanoma and treat it based on a pathogenic understanding of the disease. And I think this illustrates that point quite clearly, but also emerging data with the Plexicon BRAF inhibitor also further emphasizes that a genetic understanding of a disease, including a disease as inherently refractory as melanoma, can lead us to improved therapeutics. Next slide. So I've created a list of those diseases in which I believe that there is a known genetic driver mutation and a therapy that is currently approved or in clinical trials for that disease. And I think you can see this spans the gamut from hematologic malignancies to rare pediatric tumors such as to lung cancer and melanoma, again, an inherently refractory disease. So I think this paradigm, far from being sort of an isolated example confined to CML, is really much more prevalent and hopefully will continue to grow in its prevalence over time. So the question is, if we really think about the model of drug discovery or drug development that's been elaborated by this paradigm, which I show on the right, and contrast it to the model that we've been operating on for some time, shown on the left, we can sort of see these progressive attempts to increase. Is there a pointer that actually that works? No. Yeah, I need a pointer if possible. So you can see under Model A, what we've been trying to do is through a series of empirical experiments without really understanding the pathogenesis of the disease, we've been trying to add sequential forms of chemotherapy to a given unselected patient population and gradually improve the survival curve in this progressive manner. Whereas on panel B, we can see a model in which the genetic understanding of the disease, again illustrated here by KIT mutant melanoma, might enable us to do much smaller focused clinical trials with much greater benefit to specific patients. Next slide. So if we're going to implement Plan B or shift from Plan A to Plan B, it's worth considering what the problems are that might block us from going from Plan A to Plan B in a more robust or faster manner. And the first one, of course, is in order to understand cancer from a genetic perspective, one would have to know all the genetic alterations in all of the cancers. And we still don't know that, despite the advent of high-throughput sequencing. The genome projects that might really evaluate fully the genetic alterations in cancer are just really ramping up now. I think this is exemplified by the fact that a oncogene known as ARID1A was discovered to be mutated in 40% of ovarian cancer just last week, suggesting we still have a ways to go before we know the major genetic alterations. So I'm not going to spend any more time on this, but I think it's worth considering that we need to finish this, and hopefully within 5 years we'll have that done. Now, the second problem that's being illuminated by the ongoing sequencing efforts are the fact that as we're sequencing more and more tumors, we're in fact finding out that we actually know most of the genetic alterations, or a lot of them. And this includes the finding that P53 mutation, every time we sequence a new tumor, is coming up as the most common genetic alteration in human cancer, something that we've known about for 20 years. And that illuminates this problem. Problem number two is that most known genetic alterations have not led to drug candidates. And so this remains a fundamental block, and I'll spend just a few minutes on that. Next slide. So if we think about the types of genetic alterations, they really fall into two categories, oncogenes and tumor suppressor genes. And if we think about the oncogenes like BCR-ABL, where we've made progress in making drugs, we have to also consider the oncogenes like RAS, BCL2, MYC, and ERG and ETV1, where we've known about these genetic alterations for some time, but have not made any progress in directly inhibiting the function of those oncogenes. So how can we take on that problem? I think this is an example that really was demonstrated by Abbott, in which they elaborated ABT737, an inhibitor of the BCL2 oncogene. This was something like a 10-year effort to make an inhibitor of a protein-protein interaction surface, an area that traditionally many drug companies would have shied away from. But I think increasingly we need to take this type of risk to expand the druggable universe. And their lead candidate, ABT263, is currently in phase 2 trials. Next slide. So oncogenes, we might expand the universe of druggable oncogenes by taking on these difficult-to-drug targets like transcription factors, for example. But in the tumor suppressor field, it's even a more challenging problem, because in the tumor suppressor field, we have the problem that the given alteration is actually missing. That is, the protein that's targeted by the genetic alteration generally is absent or has a loss-of-function phenotype. So restoring normal signaling to a pathway that's disrupted by a tumor suppressor protein has been traditionally very difficult. But even there, I think there's been some progress recently, and there's at least two ways we can think about this. The first is, if we can identify a direct downstream dependent node in a tumor suppressor pathway, we may be able to reverse the transformation phenotype that's been set in progress by the tumor suppressor mutation. And this is exemplified, and I'll show you in the next slide, by progress in targeting the hedgehog signaling pathway. And I'm going to use the hedgehog pathway in the rest of the talk as an illustration of both targeting a tumor suppressor pathway and also trying to understand resistance, which I'll talk about a little later. So the hedgehog pathway begins with ligands binding to a receptor called patched, which is then a repressor of the smoothened receptor. Mutations in cancer, primarily in medulloblastoma and basal cell carcinoma, consist primarily of deletions or inactivating point mutations in the patched receptor, which lead to smoothened activation and then downstream signaling through the Glee transcription factor family. And this led to the hypothesis first really proposed by Phil Beachy that patch mutant tumors would be dependent on smoothened activity. So at Novartis, we've been making a smoothened inhibitor known as LDE-225. It is now finishing phase 1 clinical trials. You can see it inhibits the downstream reporter Glee luciferase activity with 7 or 13 nanomolar IC50s, but doesn't really inhibit a control or Wnt signaling luciferase reporter. And if one then takes a, next slide, mouse model in which a tumor has been induced through mutations in the tumor suppressor patched, and we give increasing doses of LDE-225, you can see that, as shown in the blue line, we progressively, in a dose-dependent manner, inhibit Glee transcription. This is a very nice dose response, and satisfyingly, it results in a dose-dependent inhibition and then regression of tumors, suggesting that, in fact, at least in the mouse, patch-deficient medulloblastoma is, in fact, dependent on the smoothened receptor. In humans, we've been conducting the phase 1 clinical trials as well. This shows skin biopsies on patients at increasing doses, measuring the reporter activity, the Glee transcription reporter, and you can see with increasing doses up to here 1,500 milligrams per day, we're getting close to, at 1,500, 100% target inhibition. Now, we've had a few patients with medulloblastoma and basal cell carcinoma in the trial. This is a patient who had a cerebellar lesion, a 39-year-old male with refractory medulloblastoma who had been previously treated with radiation surgery, multiple chemotherapy regimens, autologous bone marrow transplant, and Avastin, but had a dramatic response by cycle 2 on LDE-225. So I think this does suggest that in a tumor suppressor syndrome, if one identifies the optimal node downstream in a tumor suppressor pathway, of course that node would have to be then druggable, one can begin to target through therapeutics tumor suppressor pathways as well. Another example of this, I'm going to skip this slide, next slide, is in the case of the PI3 kinase TOR pathway, in which we've known for some time that deletions of the tuberous sclerosis complex lead to activation of TOR and activation of S6 kinase, and that in Drosophila, if you delete S6 or inhibit TOR, you can reverse the phenotype induced by deletions of the tuberous sclerosis complex. Next slide. In a proof of concept experiment that was done in Drosophila, one can see that if one mutates the tuberous sclerosis gene, one gets a small larval phenotype as shown here, and that's reversible by inhibiting the immediate downstream target, the TOR kinase, with, in this case, an allosteric inhibitor of TOR known as RAD001. So this has led to a clinical trial of RAD001 in patients with tuberous sclerosis that harbor a rare form of brain tumor known as subependymal giant cell astrocytoma, an example of which is shown here. Patients at the University of Cincinnati Hospital were treated with RAD at 5 or 10 milligrams per day, and 95% of the patients had tumor volume reduction with a response rate of 30%. No patients progressed on the trial, and just this last Friday, the FDA approved Afinitor for patients with tuberous sclerosis that have this particular mutation. So I think this is a second example of a tumor suppressor syndrome caused by inactivation of TSC1 and 2 complex, where an immediate downstream consequence is understood, it's druggable, and the drug has the appropriate effects in human clinical trials. Next slide. So the second way we can think about tumor suppressor pathways and the undruggable oncogenes is this concept known as synthetic lethality. If we don't have a druggable lesion right in the tumor suppressor pathway itself, we may have to find a lethal phenotype or a lethal node somewhere else in the cell or in an alternative pathway. And many people have sort of called this concept synthetic lethality. It's really sort of a perversion of the yeast synthetic lethality, in which two viable mutations, when combined together, create a lethal phenotype in the yeast. In cancer, we consider this a genetic mutation, which of course creates a viable tumor, a drug which has a therapeutic index, but when we combine the mutation and the drug together, we get lethality of the tumor and hopefully a therapeutic index in the host. Next slide. We've been conducting synthetic lethal screens using pooled shRNA technology in order to try to identify additional nodes in tumor suppressor and oncogene pathways, using next-gen sequencing to deconvolute the results of these pools. Next slide. Here's an example in which several thousand genes were inactivated in a pooled screen by shRNA, in which those shRNAs that inhibited the growth of BRAF mutant cells were identified by depletion. And you can see you identify not only BRAF, but the downstream dependence of MEK1 and ERK2 in this particular example. Next slide. So, next slide, please. So, if we were to develop successful therapeutics targeting either oncogenes or tumor suppressors, as I've just described, we know that one drug is not going to satisfy us in terms of getting to the curative therapy. And this is at least in part because we know that resistance will develop to targeted agents. Next slide. This was first exemplified by the work of Charles Sawyers in characterizing BCR-ABL mutations in patients that were insensitive or relapsing to imatinib. He found a number of those mutations caused resistance to imatinib by disrupting the binding to imatinib. And we've been working on a second-generation inhibitor to try to overcome some of those resistance mutations. In trying to defeat the resistance that's occurred to imatinib, we've generated a second-generation BCR-ABL inhibitor known as nilotinib. And I just wanted to show you some of the characteristics between imatinib and nilotinib because I think it illustrates one really central feature of targeted therapeutics. So if we look at imatinib and its ability to inhibit BCR-ABL either in a cellular autophosphorylation assay or proliferation assay, it's actually a modest inhibitor by sort of normal kinase inhibitor standards. This would be considered sort of weak, a 200 nanomolar inhibitor. It inhibits KIT with an IC50 of 108 nanomolar. It does not inhibit SRC at kinase family members, and it has a plasma trough of about 260 nanomolar. Nilotinib really improved one feature of imatinib, namely the binding and inhibition of BCR-ABL by about 10-fold. So now it's a 20 nanomolar inhibitor of BCR-ABL. It maintains about the same IC50 of c-KIT, doesn't really change SRC or other kinase activities, and achieves nearly the same trough level. So in some ways, the clinical experiment that's now been done is a direct testing of the hypothesis, if I make a better ABL inhibitor, do I get better efficacy? Instead of asking, if I change the characteristics of the kinase profile, if I add additional inhibitory activities, so what's the result of simply making a more potent ABL inhibitor in CML? And that was recently answered, next slide, in a randomized clinical trial of nilotinib versus imatinib in frontline CML. And these are the results. This is showing molecular response measured by PCR. And you can see in the white bars, imatinib at 12 months achieves a 22% molecular response, major molecular response rate, whereas both arms of nilotinib nearly double that. More importantly, even though I showed you the death rate from CML has been dropping dramatically, on the next slide, you can see that if you look at the early emerging data from these trials in terms of progression to accelerated phase or blast crisis on this treatment, 12 patients in the imatinib arm progressed during the trial to blast crisis. In both of the nilotinib arms, which are each the same size as the imatinib arm, only 3 patients progressed. So I think we can say that if you want to target an oncogene, you want to make the best, most selective potent inhibitor possible, and that this will be one of the keys to trying to overcome resistance in the future. Now, next slide. Now, one of the things that we also learned from the treatment of CML with imatinib from the work of George Daly was that one could start to anticipate resistance mechanisms before you get to the clinic and start to make second-generation inhibitors or more potent inhibitors before you've even understood the results of the first inhibitor. So we've taken that approach with LDE-225, and I want to show you some of the lessons we've learned about resistance to LDE-225, even though our clinical trials are just sort of in midstream. So I showed you this slide before, which I cut off right about at day 16, which was the nicest part of the graph to show, which is where all the tumors had regressed. But much to the credit of the drug discovery team, they actually carried this study out to about 51 days. And even though I showed you that at 20 milligrams we had a complete response rate that was better than at 5 and 10, what's clear is that the mouse tumors relapse very quickly on 20 milligrams, and there's a continued dose response out to 160 milligrams, though even at 160 milligrams, 8 times the dose where we first see complete response, we get resistance. And so this says two things. One is it's almost impossible to tell what the optimal dose is. I've shown you 3 different dose response curves: the inhibition of luciferase as a PD marker, the inhibition of tumor growth in its initial response, and then the third dose response, the relapse after treatment. And the first 2 would have been consistent at 20 milligrams, but development of resistance seems to suggest that higher doses would have been better. At any rate, the observation that there was resistance in this genetically engineered mouse model gave us the opportunity to harvest those tumors and understand the resistant phenotype, and we did that by comparing sensitive tumors and resistant tumors, both at the expression level, by DNA copy number analysis, and by sequencing. So the first thing we did is to look at the expression data to ask whether we could see pathways that were initially high or on in the untreated case were inhibited during treatment and then also turned back on during resistance. And you can see this pattern of high, low, high, as shown here also. And the top matching pathway, not surprisingly, was the hedgehog pathway. That is, the hedgehog pathway was on in the sensitive tumors, turned off during treatment, but turned back on during resistance. So, of course, one question is, what's the reason the pathway is being reactivated? Next slide. So based on the imatinib experience, the first thing one might surmise is that there were mutations in smoothin that were disrupting the binding of our inhibitor to the receptor. So we sequenced 138 resistant tumors for the extracellular domain of the smoothin receptor. But in those 138, we only found 6 or 7 mutations in these tumors that could confer resistance at the molecular level to smoothin. So while genetic alterations in the receptor can occur, they weren't clearly the dominant form of resistance, at least in this particular case. So the next thing we did is look at genetic alterations at the chromosomal level by CGH arrays. And in this case, in a significant number of tumors, we found amplification of a focal amplicon that turned out to amplify GLE2, the downstream transcription factor that I showed you was at the bottom of the pathway. Next slide. To further characterize this, we looked at GLE1, GLE2, and GLE3 by quantitative PCR at the DNA level to look at copy number abnormalities in those 3 genes. And you can see about half the tumors increase the level of GLE2 copy number but don't change GLE1 and GLE3. So about 50% of the tumors can be accounted for by GLE2 amplification, and we don't know what the rest of the tumors are doing in order to activate the pathway. Now, the problem with GLE2 amplification, of course, is it's a transcription factor, and it falls back into the category of targets that are no longer druggable. So we thought, well, perhaps there would be a pathway that is cooperating with the hedgehog pathway during resistance that might have a druggable target. And so we went back to the expression data and looked for a different pattern of expression where we might look for a pathway that was off initially in the untreated tumors, off during treatment, but then only turned on during resistance. And when we looked at the expression profiles for that particular target, next slide, you can see now you have a off, off, on pattern. That's, of course, the pattern we were looking for. And when we subjected the genes that are ranked by this pattern to a form of analysis known as gene set enrichment analysis, then we scored a number of pathways. You can see here IGF-1R, PIP3, AKT, bad phosphorylation, those pathways all having in common the fact that they represent signaling through the PI3 kinase pathway. Next slide. So this suggested that in cooperation with hedgehog reactivation, PI3 kinase signaling might be playing a cooperative role in mediating resistance. And that led us to try one of our PI3 kinase inhibitors, an inhibitor known as BEZ235, in combination with LDE225. And you can see a significant attenuation in the resistance in this combination. Next. So the third problem that I mentioned to implementing this plan B was that resistance develops to targeted agents, but that, of course, gives us the opportunity now on the targeted therapeutic paradigm of understanding resistance at an early stage and trying to develop novel combinations at a much earlier stage than after the drug is already on the market. Now, this also, of course, basically leads us to the conclusion that one drug will never be enough, and I think we've known that for many years of trying to treat cancer patients, that we're going to have to use combinations. And the question is, how are we going to find the right combinations? So I want to go, next slide, back to this model. Right now, our model of finding combinations is to take some new drug, add it to a bunch of old drugs, and hope that we get something like this, plus the new agent on top of something like cisplatin and gemcitabine, and hope for a 10-year history of progressively elevating that curve. But what I hope for, and whether this is true or not, I don't know, is, again, plan B. That is, we will find novel combinations that have much more dramatic activity than we expected, perhaps that we can find in small phase 2 trials, and then we can focus our efforts on those novel combinations, potentially changing the therapeutic paradigm for that particular type of cancer. Next. And I think the work of Jeff Engelman and Lou, Jeff will probably talk about this, was illustrative of this, so I won't go over that, but Jeff and Lou basically found that if you combine PI3 kinase and MEK inhibitors to interrupt both of these pathways, you got significant therapeutic efficacy combined to just the single agent therapy. Next. Given the time, I'm going to skip this slide. So, in terms of these combinations, that Jeff's work was an example of a hypothesis-directed combination. We can also imagine on the next a large-scale combination screen is something we're undertaking with a company called Combinatorics. Next, to try to test all of the relevant compounds across all of the relevant compounds across 100 representative cancer cell lines. Next, in a screen that's going to result in the testing of 9 million combination triads. So this would be one way to try to find special combinations through a preclinical screening effort. Next. Let's go to the next slide. So the final problem that we've had in drug discovery is illustrated in the next point. That is, we've never been able to really preclinically characterize or predict clinical efficacy based on a rational preclinical set of experiments. And this is largely because we haven't had a translational infrastructure in which to do this. Next slide. In any case, I think we've lacked two aspects of the translational infrastructure. One is a set of models that are well characterized and reflective of the disease we're trying to treat. And then the second is a capacity to screen those models in enough detail that we would have be able to build predictive understanding of whether a given new therapeutic will have activity in a given set of patients. So in addition to the cell line models, we've also been building a primary human tumor model collection. It's now totals 291 primary human tumors that are grown only in mice. The distribution of the tumors is shown here. These are also being characterized at the genetic level to allow us to now use tumors that perhaps are not conditioned to growing on plastic dishes. Next. So I want to go back to this, this paradigm and just summarize the 5 points I've made and try to, again, reinforce potential solutions to those 5 problems that I've articulated. Next. First, we need to complete the cancer genome in depth to address this lack of understanding of the genetic alterations of cancer. Next. We need to work on validated, difficult-to-drug targets like RAS and MYC that we know are important drivers, but we have been unable to target. Discover synthetic lethal drug targets either for undruggable oncogenes or for the tumor suppressor lesions. Study resistance preclinically and come up with combinations that address that or new inhibitors. Next. Discover novel, highly active combinations, test them early in development, not necessarily in combination with existing therapeutics, and find those combinations that are highly active and more likely to lead to a transformational benefit to patients. Next. And then finally, build a robust preclinical and translational infrastructure to allow us to make better predictions for the clinical trials going forward. And with that, I'll wrap up and thank many of the patients that have been participating in our clinical trials. And I have the great pleasure to work with a lot of great scientists at Novartis and in our academic community, and been very happy to be here and happy to address questions.
we have time for a few questions. Let me just grab a microphone. Is this on? No. Let me start with just a philosophical question about how optimistic you are. About a couple of years ago, people would have argued that maybe 10% of all cancers have a single gene defect or targetable gene defect, and drug companies are going to be making more and more drugs against the same targets. When Novartis now looks at the next 5 years, where do you set the bar? What frequency or what fraction of cancers you think will be benefiting from targeted agents?
Yeah, so that's sort of unknowable. Of course, if we made a RAS inhibitor, it would be 90% of pancreas cancer, right? So I think I flipped the question around the other way. What proportion of cancers are driven by driver mutations? And I think all of them. What proportion can we drug today? It's a minority. What proportion can we drug in the future, either by inventing new mechanisms of therapeutic inhibition, such as siRNA or protein-protein interactions? I think it's going to be high. So I'm, of course, the ever optimist, but I think we're on the right track. In terms of the fraction of patients we care about, it's one of our models is that even if at first ALK would be a perfect example of this, the ALK mutations in lung cancer, which were first only known in neuroblastoma, which was an orphan small disease. You know, had someone said, I'm going to work on ALK in neuroblastoma, you'd be well positioned to work on ALK in lung cancer. So that's our philosophy also. It's more about, do we understand the pathogenesis of that particular target in that disease with the hope or expectation that it might be much larger later on. And sometimes it won't be, sometimes it will be.
Bruce?
Bill, you made an important point about increasing potency with nilotinib. It also, as I understand it, has activity against some of the maybe the weaker mutations that lead to resistance. The other problem with potency is that you often see an increase in the toxicity when you increase potency in terms of the dose that you can give. So overall, do you think nilotinib succeeded because of its increased potency or because it was able to overcome certain mutations that confer resistance?
Well, I think in many cases, you're probably, in the case of early treatment in CML, you're probably preventing the resistance from developing in the first place. Of course, in second-line therapy, it had to work in resistant mutations. But I want to go to your therapeutic index question. ABL turns out to be fairly unique. That is, you can inhibit ABL as much as we can possibly inhibit it, and it seems to have no consequence on the adult organism. This is not true for almost everything else. So for PI3 kinase, we get hyperglycemia. For the smooth-end inhibitor, we actually think we have a really good inhibitor because we're seeing muscle cramps and CPK elevations, which we think is an on-target effect of inhibiting smooth-end. So the better we make the drug, the more on-target will our dose-limiting toxicity be. Now, the problem I see is we get to the dose-limiting toxicity, which we're saying is 100% target inhibition, or our best measure of target inhibition, and then we reduce the dose. Okay, so that if we had done that in the chemotherapy regimen we would have cut the dose of cyclophosphamide in half, cut the dose of adriamycin in half. We would have practiced this dose reduction in a way that would have been detrimental to the ultimate cure of some of the tumors that were cured by chemotherapy. So I think when we have dose-limiting toxicity that's on target, we do need to start thinking about the paradigm of mitigating the toxicity by second drugs, so metformin for hyperglycemia or insulin. We have to start changing the scheduling so that we can have potent inhibition for a period of time and then a recovery period. And in fact, I would say that imatinib, Gleevec, has done some damage to that paradigm in that now everybody thinks we should just give the drug every day and no one's going to have any toxicity, and that's the paradigm. I think it's actually quite different, especially when we go to combinations. It's going to be back to intensive therapy with holidays, and we need to start doing more of that.
Second question?
I can hear you.
Considering the ever-present criticism that cell lines do not really represent primary tumors, have you compared in detail your xenografts you established in the cell lines, and did you actually get any benefit from using xenografts versus cell lines in your screens or your genome studies?
Yeah, so I try not to make very strict, it's going to work for this, and then if it doesn't work for everything, we're going to abandon it. So cell lines are very good, of course, for cell-autonomous genetic-driven events. So, you have ALK mutation in lung cancer, ALK mutant cell lines are highly reflective. if you have pathways like Wnt signaling and hedgehog signaling and more of the development pathways, which are often paracrine, they are of no use in cell lines. And in fact, in our primary models, hedgehog signaling is a robust player in the pancreas tumors, for example, that grow in the mouse. Even then, of course, it's not ideal because we have mouse stroma growing, supporting human cancer. And we know a number of examples already where receptors and ligands don't cross-mix. And so I think that's where GEMs are going to come very useful, where you can study GEM models of human cancer in their normal stromal environment. So I think all three of those are the sort of foundation, and we use them as needed to address certain types of therapeutic questions.